Hello everybody, welcome again to another case in our case study series. This is the case number 6, patient with chronic abdominal pain. Let's start. So, the case presentation said a 28 years old man present with 8 months of crampy periumbilical and right lower quadrant pain with 5 to 7 loose stools every day, intermittent rectal bleeding, 6 kilogram weight loss, and profound fatigue. Over the past 4 months, he has developed insidious low back and alternating buttock pain with more than 1 hour morning stiffness, improving with activity. The patient reports episodic swelling of the right knee and the left ankle. The family history is positive for colitis and maternal ankle, and vitals are within normal limits. So as we usually do, we start with our physical examination if there is no emergency in the case. So here there is no emergency, so we will proceed with our physical examination. We can stop here and think about which physical examination we should do. So we'll carry on. We start with a general physical examination. The patient looks pale and mildly dehydrated. There is no jaundice. The CBC shows a normal heart sounds, low-grade systolic murmur heard at the left sternal border, otherwise unremarkable, normal blood pressure in all extremities. Respiratory is normal, nothing count here, no crackles, there's no wheezing. Abdomen, actually this is the top here, shows a diffuse tenderness, maximal to the right lower quadrant with a vague tender mass. Liver spleen edges within normal limits. Skin show a pale skin, multiple painful nodules like lesion over the both shins. Musculoskeleton show reduced lumbar flexion, sacroiliac joint tenderness, asymmetric right knee, left ankle effusion, Achilles tendon and plantar fascia insertion tenderness. So as we look here, there is a multiple symptoms, multiple manifestations here, abdomen, extremities, skin, etc. Okay, so according to this physical examination, we will start to form our differentials. Okay, before we dive to our differential, I would like to aim it to an important point here in the cardiovascular system. The low-grade systolic murmur, this is the normal. This is because of the patient is dehydrated, so the heart is working than the normal capacity, so that's why we see murmur. And specifically it's low grade and it's in the left sternal border. Systolic murmur could be normal, but diastolic is never ever normal. Okay, so pause here. So the symptoms, think about your differentials, and we will carry on. So before we carry on, so this is how the rash, this is how the nodules that was mentioned in the physical examination looks like. Look at them. Going back to the physical examination, you can pause here, think about your differentials, form them, put the first one as the most likely diagnosis, and go on like this. So you can pause and let's carry on. So the differentials is like this. The first thing is Crohn's disease with extra abdominal symptoms, which is seronegative spondyloarthropathy, and the second thing is ulcerative colitis with IBD related arthropathy. So what we can see here, that we put at the first two differentials are IBD, since IBD is causing a chronic abdominal pain with weight loss, also bleeding, diarrhea, and we saw an extraintestinal manifestation like arthritis. Also this patient had sacroiliitis, I believe. So that's why we put IBD as the first differentials. Then comes reactive arthritis after enteric infection. Okay, there's a lot of symptoms here correlate with reactive arthritis, but it's in the it's not in the top because we We didn't show any conjunctival erythema or main conjunctivitis. There is no also any genital lesion, etc., confirming reactive arthritis. So that's why it's not in the highest differential. Parasitic infection, always spotted. It's been 9 months. Patient has diarrhea, etc. So this is also could be parasite. Celiac associated enteropathy with arthritis. Also the same concept here. Patient had a diarrhea, chronic, and young patient could be celiac. Okay. Then comes the last one, C. difficile associated megacolon. Always put this in your differential in case of chronic diarrhea with weight loss and tenderness like mass. It could be C. difficile. Okay. So pause here. According to those differentials, you will do your workup. So you order your labs, your imaging, etc. So you can pause here, think about what type of labs or imaging you need to order, and we will carry on. So this is the workup here. We ordered CBC, CMP. The CBC and the CMP because we had a diarrhea. Also, there's a rectal bleeding and weight loss. So we want to see how much is the hemoglobin. Do we need to transfuse or not? Is it an emergency case or not? So that's why we're the CBC and CMP, which we want to check the sodium, potassium, and the electrolytes, calcium, etc. Because the patient been having diarrhea for a long time, so we need to check those electrolytes. ESR, CRP, always here in this case because we have a assumpted diagnosis that it could be Crohn's or ulcerative. So we need to know if there is a long-term inflammation, and specifically by using ESR. CRP will let us also know if there is inflammation or not. Combining both of them is the best to get the full picture about a chronic inflammation happening in the body. Okay, rheumatoid factor, that is important because this will help us to rule in or rule out seronegative spondyloarthritis. Okay, this will help us actually rule in out. If it's positive, then this is maybe because of other rheumatological disease. It could be rheumatoid arthritis or systemic lupus, etc. Abdominal X-ray combined with a sacroiliac X-ray. This is because the patient had a symptom of back pain with morning stiffness, etc. We want to confirm ankylosing spondylitis using those X-rays. Fecal calprotectin. This is used for confirming, not confirming actually, but it will support your diagnosis in case of IBD, specifically Crohn's disease, because this is an indicator of bowel inflammation. Okay. Anti-endomyosal, this is to rule in or rule out celiac disease. It's highly sensitive. Stool culture and ovoparasite and C. difficile fecal test. Stool culture with the C. difficile fecal test for confirming C. difficile if it's presented or not, right there. And also ovopen parasite to rule in or rule out parasitic infection. Okay, and the most important is ileocolonoscopy. Usually you will not through colonoscopy or endoscopy at the beginning in your differentials, but in this case there is a rectal bleeding with weight loss and also diarrhea for a long time. The patient is pale, so there is a couple of alarm features here that guarantee a urgent colonoscopy. Okay, but in differentials like Crohn's and ulcerative colitis, usually colonoscopy it's not the first choice. Okay, you will need it to confirm diagnosis, but it's not the first thing you will do in the workup. So those are the values which is we got. CBC and CMP. CBC show a macrocytic anemia with thrombocytosis. also a high leukocytosis. That is a picture showing that there is a long-term inflammation happens in the body, and the microcytic because of iron deficiency, the rectal bleeding that happens for a long period. Folate are low to normal, and B12 are also in the borderline. The other electrolytes are normal. ESR CRP is high, confirming that there is a long-term inflammation in the body. RF is negative, so this is a ruling in actually seronegative spondyloarthropathies. Okay, abdominal and sacroiliac X-ray show bilateral, largely symmetric sacroiliitis with subchondrial sclerosis. Okay, so if you can just stop here and get to those first 6 labs, you already have a diagnosis of ankylosing spondylitis here. Okay, but you need to carry on to see if there's an IBD or not. So fecal calprotectin is positive. That's indicator of there is an inflammation in the bowel. The anti-endomyosal is negative, so there is no celiac disease here. Stool culture and ovum parasite and C. difficile fecal test, all of them are negative, ruling out C. difficile and parasite. And when we done the colonoscopy with the biopsy, and of course you needed to do it with biopsy because your high differential are Crohn's and ulcerative colitis, you don't order colonoscopy without biopsy. You need biopsy, okay? So you'll see a patchy transmural appearing ulceration with a skip lesion involving terminal ileum and colon, which is compatible with Crohn's disease. Okay, so here we have a diagnosis of Crohn's disease with extra-abdominal symptoms, or if we want to be specific, that's an IBD with a seronegative spondyloarthropathy. Okay, so let's actually dive in a little bit in Crohn's disease, or IBD in general means Crohn's disease and ulcerative colitis. Okay, and it's an idiopathic inflammation happening in the gut for a long period. It's like an autoimmune disease, the same concept with other autoimmune diseases, but the cause itself is idiopathic, it's unknown. It has a bimodal age presentation, and that is important, and I want to stress enough over this. Knowing the age of the patient will give you a lot of hints, especially in exams. If the patient is in 20s, 30s, and had the presentation of abdominal pain for a long period, put IBD in your first differentials, because it is common in 20s and 30s. Okay. The risks also, there is another this permanent second peak, which is around 7th and 8th decades. That's actually interesting. But if they want to ask you in the exam, they will ask you about 20th to 40s. Okay. Risk factors. There's a 10% risk in the first degree relative. So if the question, for example, this patient had a relative who had colitis, so that's actually putting you in the same direction of Crohn's. Also, it's common in the Ashkenazi Jewish descent for they have a risk for IBD. Here is important, another point, which is they always ask in the exam. Tobacco smoking is protective against ulcerative colitis and increase the risk for Crohn's disease. The cause of the idea or the pathophysiology around this is it's unknown. It's weird that how tobacco is protecting against ulcerative colitis, but that is a question actually. It's asked a lot in board exams. Okay. Patients with IBD have increased risk for colorectal and cervical and skin cancer, and it's important to know which IBD is causing cancer and which one is not. And in colorectal cancer, we see this a lot with ulcerative colitis. Okay, so if you're in the exam and they ask you about a risk of cancer associated with IBD, most of the time they are hinting to ulcerative colitis. Okay. So the clinical presentation, we have two symptoms, which is the abdominal symptoms and the extra intestinal manifestations. Okay, IBD can only present with an intestinal manifestation or abdominal symptoms. So the patient can have a chronic pain. If it's Crohn's, it will present mostly in the right lower quadrant, mimicking appendicitis-like pain, and the patient usually will have this pain for a long period with diarrhea, and also if the patient had a poor nutrition, will have also weight loss, as we saw in this case. There is some intestinal complication, and that is specifically seen with the Crohn's disease, like abscesses, strictures, and also fistulas. Okay, and that is important actually. If they bring like any case, or for example, if they ask you in the exam about the case who had a fistula or strictures or abscess, this is mostly Crohn's disease until proved otherwise. Okay, because Crohn's, this is the thing which is caused a stricture and fistula comparing to ulcerative colitis. Extraintestinal manifestation could be erythema nodosum, which is we saw in this case in the picture. It was erythema nodosum. Also, we have pyoderma gangrenosum, peripheral arthritis, uveitis, and primary sclerosing cholangitis. Okay, all of those symptoms can be seen in Crohn's or ulcerative colitis, but there is symptoms which is more common in Crohn's, and the others are more common in ulcerative. So for example, erythema nodosum, you will see it more with the Crohn's disease. That doesn't mean that you will not see it in ulcerative, but it's more common in Crohn's. Pyoderma gangrenosum, this is more common in ulcerative colitis. Peripheral arthritis, we will see it in both diseases. Uveitis also in both. Primary sclerosing cholangitis, that is common in ulcerative colitis, and this is a common question in the exams. Okay, always when you have ulcerative colitis and the patient start to present with a right upper quadrant pain, jaundice, etc., think about primary sclerosing cholangitis. Okay, so here you can see the symptoms, the skin manifestations, and also the uveitis. Sometimes they will not bring a picture in the and here I'm stressing in the exams, they will not bring a picture. They will only give a description of the lesions, so be familiar with those. So if they say a lesion, a painful lesion in the chin, or like a painful lesion in the legs, think about erythema nodosum. If they say a volcano like lesion, okay, with a symmetric border, this is mostly pyoderma gangrenosum. And uveitis, you can see here in front of you. This is inflammation of around the uvea of the eye. So the diagnosis, you need the clinical manifestation, plus it's important you cannot diagnose Crohn's without the endoscopy. And it depends that if it's endoscopy or colonoscopy, depends with the clinical picture. So this patient had rectal bleeding, that's why we don't call colonoscopy. We want to try to reach to the colon and see where's the problem. But also you can use endoscopy. Okay, both of them are acceptable, and you need to do it with a biopsy. Okay, it's important, you need to take biopsy, because otherwise you cannot diagnose Crohn's. And what do we see under the microscope? A characteristic mucosal feature of Crohn's disease will show a skip lesions, which is seen in this picture. Skip lesion. This is the lesion where it's affected here, and it's skipped here. So this region is normal, and this region is affected. Okay, which is the circle around it. Also, we can see here in this picture, you can see a cobblestone like appearance. This is also seen in Crohn's disease. Here under the microscope, we can see something we call it non-caseating granuloma. Okay, this is seen with the Crohn's disease. That is the granuloma itself. It's non-caseating. A way to diagnose Crohn's. Okay. That's here we have a good figure shows the difference between ulcerative and Crohn's disease. We mentioned Crohn's has a skip lesion, so it could happen in the transverse, then to the descending, then the ascending, and then takes the small intestine. That's how Crohn's present. Plus, the inflammation will take the whole layer, so it's a transmural. But when it comes to the ulcerative, it only takes a specific region, but it's continuous, and the inflammation will only take the mucosa. Okay. Let's carry on. Okay, that's actually important table comparing ulcerative colitis from Crohn's disease. It is important to know the difference between Crohn's and ulcerative. You can guarantee in boards exam they always ask this. So for example, the depth of inflammation, if it's a transmural or mural, which one is causing fistula and which one is not, and also which one has granuloma. But as we saw in Crohn's disease has non-cascading granuloma, which one is affected by tobacco and which one is not. That's also important. Also the location of it. The Crohn's disease mostly is the Crohn's from mouth to anus, so it can happen anywhere in the GI. Ulcerative, it's only taking the colon, okay, the colorectal. So that's an important table. For the treatment, treatment of Crohn's disease will have the same concept as any treatment of chronic inflammation, okay, but there is some key medication here we're gonna use, specifically is 5-amino-salicylic acid, okay, sulfasalazine. Those are an anti-inflammatory drugs, which is they only work in the GI, okay. So if you give the patient this pill, it will work. It has its own capsule. Once it reaches to its target in the GI, will reduce the inflammation. Okay, so those are good medication. Usually we start with those, and then we try to put the patient on immunomodulators, for example, like azathioprine, and some biological drugs like infliximab. Okay, before starting infliximab, it's important always check for TB. So if the patient has a risk for TB or has a interferon gamma test impaired positive, this patient is not candidate for this drug. Okay, so that's how we work. We start with sulfasalazine and then keep the patient on long-term immunomodulators or biological drugs. Steroids could be used in case of flares, but they're not in long-term regimen. Okay, if the medical treatment are failed, or if the patient agreed to do a surgery, sometimes we do surgery to remove a specific part of the bowel which is affected. And in case of Crohn's, sometimes the patient needs to take the whole bowel, which is a complicated situation. In this case, patient will only start taking their nutrition by parenteral IV nutrition. Okay, and also we can use surgery to fix or correct some fistulas specifically, which is they drain so much. We can close them by surgery, and also fibrotic strictures. And last point, which is the healthcare consideration here, it's important. We need to give a vaccine for patients with Crohn's disease, because they are susceptible to get infection, actually, to get infected every time. So we need to vaccinate them as we're dealing with a patient with immunocompromised like picture. Okay, so we will give COVID-19, for example, vaccine, or pneumococcal vaccine, and also influenza vaccine. Okay, this is important for exams like CCS or USMLE Step 3. You need to order those vaccines in the follow-up after the end of the case. Okay, and always consult a gastroenterologist, specifically in IBD, because this is a chronic inflammation, chronic processes. The patient will be in a couple of drugs. They need to be followed up by a specialist. Okay. Thank you all for being today in this case. See you in the next case.